Yeah, some people really struggle with it. Some people will be forever sterile. Some people need help.
I'm gonna have a procedure done to get my tubes untied so that I can have another baby.
Coming up on The Local Show, KCPT examines a $5 billion industry that is pushing the frontiers of medicine, infertility.
We track the issue through the eyes of 3 local couples.
We chronicle their stories, talk with doctors and ethicists, and take your calls.
Birthing Pains, an hour-long Local Show special, is next.
Major funding for health coverage on KCPT provided by Assurant Employee Benefits and the Healthcare Foundation of Greater Kansas City.
Hello, I'm Nick Haynes.
And I'm Cynthia Wheeler. On July 25, 1978, the birth of Louise Brown in England gave hope to infertile couples around the world. Known as the world's first test tube baby, the infant was the first child born through the then revolutionary procedure known as in vitro fertilization, or IVF.
Well, more than 4 million babies have been born that way since, and the medical breakthroughs seem endless, from surrogate moms to young women freezing their eggs, to the latest breakthrough of a woman who's about to become the first in the world to give birth to a baby from a transplanted womb.
It's a $5 billion industry, and while more than 7 million American women suffer from infertility, much of that care isn't covered by insurance.
In fact, only 15 states require infertility treatments be covered by health insurance plans. Kansas and Missouri are not among them, which may be why Missouri was recently ranked 48th among states on a recent national fertility report card.
But if you have to pay for most of this out of pocket, who's being left behind? We'll take a look at that this hour, and we'll also give you an opportunity to join in on the conversation.
But enough talking for right now. On The Local Show, we joined with local filmmaker Sharon Leese to do something very different than we normally do, and that is to take you into the lives of 3 young couples as they make some really personal decisions. We also take you on a very rare medical journey into their hospital rooms and surgical units to see some of these remarkable procedures take place.
First, we meet Kristen and Brian Bookwalter, who live in Topeka. They are both 35 years old, and in their 8 years together have not been able to get pregnant on their own. They've had to try and find $10,000 of their own money to begin the long in vitro fertilization process that they hope will lead them to their dream, their own child.
Just hold it like a pencil, right?
Right.
So grab.
Pinch your skin up. There's not a whole lot, but
I didn't even feel that. To have a little mini bri.
little mini Kristen.
I can't see not having a little mini bri.
We've already been through a lot. Actually, the last 2 years have pretty much been focused around trying to have a baby. It's a lot. So we can do that. I think we can get through anything.
On our wedding day, it was raining, it was pretty cloudy. So we feel like the fact that it's also raining today, the day of our transfer, it's good luck for us. Brian and I have been together for 8 years, married for 4. Shortly after we got married, we decided not to have any type of protection or birth control, and we've never had even a pregnancy scare. So we just knew that it wasn't really going to be easy for us.
Well, most of this journey has been, what Kristen had to go through. I didn't have to go through that much. My responsibility was to give a sample.
He was just a little bit low on his count. His motility was good, but they also do a check for the number of abnormalities, and they said that was a little bit higher than they wanted. And so we decided to pursue IVF from there. In the past 6 weeks, I've made 10 round-trip journeys over to Olathe to Dr. Gilbach's office.
In the United States, approximately 1 out of every 6 couples face infertility. There's a lot of reasons for that. Male factor, blocked tubes, ovulation problems. In our country, age is a big factor as well because we tend to put off having children. Of all the treatments that we do, IVF is usually the most successful because it tends to correct multiple problems at the same time. IVF takes about 6 weeks to complete. We start with a woman's period. and she will come in for some baseline testing and ultrasound. This is for us to assess her ovaries to determine how much medication she needs for stimulation.
And the white that's floating around is just a little bit of endometrium that's getting fluffed up. The angle kind of gives us a cross section. Everything looks perfect.
Then we put her on a birth control pill, which is used to suppress the ovaries. This is done usually for about 2 or 3 weeks. She goes off of the pill and then starts into a series of hormone injections, which are designed to stimulate the ovaries. This usually takes about 9 or 10 days. Once the follicles have reached a certain size, we usually give her a hormone injection to trigger the final maturation of the eggs. We then perform the egg retrieval. Once the eggs are recovered, they're then fertilized in the laboratory that same day. They grow into early embryos. They're cultured in the lab typically for 3 to 5 days before they're transferred back into the uterus.
Part of the process during IVF is they do give you paperwork, and you do have to determine what you want to do. If you have embryo, you know, should something happen to me or something happen to Brian, or if we divorced.
It's a lot of stuff in 2 or 3 pages. It's a lot to think about.
Have you had a chance to read over and kind of make your decisions?
I think so, yeah.
Great.
The cost for IVF it's pretty expensive. In total, what we were looking at was around $15,000. But then once we discovered that I had drug coverage included, we were able to take off the additional $5,000 that we were planning for medications. I don't see this as a bad thing. I don't feel slighted or upset that we had to spend the money on it.
No, it's never really been a bitterness issue.
Yeah,
Like, man, why can't we have kids with a natural conception? It's always been, we'll just work through the problem. Yeah, some people really struggle with it. Some people will be forever sterile. Some people need help.
Kristen and Brian had to decide whether they wanted to transfer 1 or 2 embryos. By transferring a single embryo, we can reduce the chance of any multiple pregnancy, even that of twins. Transferring 2 embryos still gives a slightly higher pregnancy rate, and many couples still choose to do that. The success of IVF depends more upon the woman's age than anything else. In our program, more than half of women under age 35 will get pregnant on their first try. In Kristen and Brian's case, it was primarily a male factor. So in their case, once the eggs were recovered, we helped to fertilize them by injecting the sperm directly into the eggs. This is a procedure called ICSI. I know where we want to place the embryos. Once we've decided how many embryos to transfer, the embryologist will load a catheter with the 1 or 2 embryos and then bring it into the procedure room, where I will thread it through the cervix up into the woman's uterus, and the embryos are placed very gently into the uterine cavity, where they will attach and grow. The embryos are inside now. Nick is going to show you on the screen where they were placed.
When I think about having kids, I really think about him someday going and taking our child to Manhattan to the football games with Grandpa. That's just something I don't know why I picture that and have it in my head. The worst part is now waiting for the results. I think that's going to be the hardest part, is just the wait.
Kristen and I wouldn't have been able to have a child. And now that, kind of science makes that possible, I think that's pretty incredible.
Joining us now from Park City, Utah is filmmaker Sharon Leese, who followed the Bookwalters for us as part of this program. She's at the Sundance Film Festival, showing her new film, Selfie. Sharon, this was all shot last year. Tell us about Kristen's progress. How is she doing with her pregnancy? Has she experienced any complications?
Well, first of all, as a filmmaker, it was really, really fun to be there and filming such an important time in their lives, because Kristen actually conceived right before our lenses, so that was really cool. And she is about 20 weeks pregnant right now, and they're going to have twins, so that's very exciting. And I think she just experienced a little bit of morning sickness, but otherwise she's doing really well, and she's doing jazzercise, and she's just having a really happy, healthy pregnancy, and I'm really excited for them.
We'll check in again with Sharon Leese a little later. I want to cut right now to Nick Haynes, who is with the doctor who performed the procedure.
Cynthia, thank you. I am here with Dr. Dan Gelbach. He's a reproductive endocrinologist who you just saw. He's at the Midwest Reproductive Center in Olathe. We're also getting a second opinion on the program from Dr. Sasha Krieg. She's at the KU Center for Advanced Reproductive Medicine. And because I think this whole area brings up so many societal and medical ethics issues, I've invited Dr. John Lantos to join us. Dr. Lantos is director of the Children's Mercy Bioethics Center, and he's written considerably about these areas. So thank you very much for being with us. Dr. Gelbach, you hadn't actually seen that piece.
No.
So that's the first for you. It's amazing to me, I have to say, hearing about all of this, that this is not actually covered by insurance in Kansas or Missouri?
It is not mandated to be covered by health insurance. There are definitely some people that have coverage that help them do all types of fertility treatments, but they're in the minority.
We are hearing about people who are taking out loans, borrowing extensively from their parents. And some of these treatments, because IVFs can cost about $12,500 a treatment, Dr. Krieg. You know, sometimes we have people who are taking out loans hugely, $50,000 or more. What types of things are you seeing at KU Medical Center?
Well, absolutely. I think one thing that we don't realize is that often many patients don't end up needing in vitro fertilization, so their fertility treatment ends up being much less expensive. For example, something simple like Clomid insemination that may be as little as $300 to $500. But indeed, our patients that do go through in vitro fertilization, many do have some coverage, so they don't end up paying as much as they would anticipate, because an IVF cycle with medications does end up costing about $10,000. But many of our patients, their parents do help them pay for it, or they pay for it out of pocket. Other patients decide to finance it with one of our fertility financing companies that is designed specifically for infertility, not just in vitro fertilization, but also less expensive alternatives, and are able to finance it that way.
You know, one of the things that we also found in looking at this is when should somebody actually go to the doctor? When do you know you've actually got a problem?
That's a really good question, and that's something that I think people need to be aware of. If you're under the age of 35, so this is really an age-dependent phenomenon, you should really start seeking help after trying for a year. However, if you have a history of, say, a ruptured appendix or some sort of pelvic infection, or for whatever reason you may know that you have irregular menstrual periods, or you may know that your husband's had a testicular injury in the past, you should see someone sooner so you don't waste that year in attempting pregnancy. Now, if you're older, say between the ages of 35 and 40, we recommend only waiting 6 months, because time becomes of the essence during that period of time. And we want to find out, gosh, are your tubes blocked? We need to do something more aggressive sooner, and we want to take advantage of younger eggs. Now, over the age of 40, we recommend almost referring immediately if a woman wants to attempt pregnancy, just because by the time you get in to see a fertility specialist, you've already waited about 3 months or so. We want to make sure that there's nothing serious that we can correct, so we're not battling ovarian aging alone.
Dr. Lantos, back to the cost of all of this. You know, health insurance companies say they don't pay for this because, for one reason, is it is non-essential. And secondly, there are so many premature births and multiple births that relate to fertility. But if people are paying, though, out of pocket for all of this, why should we care?
We have to look back at the history of ethical controversy over this. In the early days, the big ethical controversy was whether it was going to be safe and whether it was going to work. The debates about IVF before Louise Brown was born were about whether anybody anywhere should ever attempt this and risk having a baby born with devastating congenital anomalies. Since then, it's been shown to be fairly safe and effective, but that ethical controversy still hangs over the procedure, and there are still questions about whether this should be a priority in health expenditures, or whether this is sort of a luxury item that people can purchase with their own money if they want, but shouldn't be rated up there with treatment for cancer or heart disease or life-threatening illnesses.
Given the huge costs associated with fertility treatments, who is being left behind? Is this only something you can do if you're wealthy? Cynthia Wheeler has been digging into that a little deeper.
We know, Nick, that fewer minorities are getting infertility treatment. Take a look at these numbers just released from the National Center for Health and Statistics. 15% of white women diagnosed with infertility received medical treatment, compared with 8% of Hispanics and Black women. Is there a racial disparity to the infertility? The most commonly cited study comes from the U.S. Health Department's Fertility, Family Planning, and Women's Health Report, which claims that while almost 6.5% of white women were certified as infertile, more than 10% of Black women and 7% of Hispanic women were classified as infertile. When you look at these numbers, I have to ask, is it about economics or is it about race?
So what about that? Is it about race or economics? Dr. Krieg?
I think that's a really good question. And there was actually a large study that came out about a year ago showing that as a population as a whole, we're grossly underestimating the prevalence of infertility, because when we look at this data, these are couples that actually came to a fertility center to seek help. So we know that there are a lot of barriers to coming to see us, some preconceived notions about how much it may cost, and that perhaps every patient needs in vitro fertilization, where more often than not they don't. But also other barriers, say our Hispanic patients that only speak Spanish, they're worried that, gosh, the doctor might not speak Spanish, or there may not be staff there to speak with them. So we aren't necessarily capturing all those patients that have infertility, but we do know that particular groups are at greater risk for certain conditions. For example, our Hispanic patients are at higher risk for diabetes and polycystic ovarian syndrome, so they're more likely to not ovulate regularly. Our African American patients are at higher risk for having uterine fibroids, which can also hamper fertility as well as cause tubal disease, amongst other things. So there certainly are with certain ethnicities, you are going to have higher risks of infertility, but I think that part of it too is access and concerns about access.
But not everybody does get to have fertility treatments, Dr. Lantos, when you're dealing with costs associated with some of these treatments being, sometimes can be in excess of $50,000.
Sure. The other thing to remember about the cost numbers that were cited in the video is that's per cycle, but on average only about a third of people who go through a cycle end up with a baby at the end of it.
Well, let's talk about the success rates. When you talk about IVF, for instance, Dr. Gelbach, what is the success rates with IVF?
I think today most programs are going to see clinical pregnancy rates over 50% in their younger patients. Age, again, plays a big role. Women over 40, pregnancy rates are going to be below or around 25 or 30%. So I think IVF is a very successful treatment. It's not necessarily the initial treatment for most couples, unless there's a specific reason to do so.
What is the initial treatment for most couples?
Again, it depends on the diagnosis. If it's just an ovulation issue, fertility medications often will help them conceive within a few months. If it's a male factor that's not severe, many couples will go through inseminations. Dr. Krieg mentioned that some couples benefit from surgeries that may fix blocked tubes or endometriosis. I think in vitro fertilization is often a treatment that is instituted when other treatments are unsuccessful.
We're going to hear more from our doctors straight ahead on this special hour-long live edition of The Local Show we're calling Birthing Pains. But first, it's time to track another couple who are seeking medical help to have a child. But as you're about to learn, this time, there's a big twist. Cynthia?
Next, Nick, we're going to meet Angela from Overland Park, a 34-year-old and a mother of two. She thought she'd completed her family. In fact, she had her tubes tied to make sure she couldn't have any more children. Well, life changes, as we're all aware of, and she's now among the 6% of women who want the procedure reversed at the cost of $6,000. It's not a procedure covered by insurance, but she's going ahead with it anyway.
We're gonna go to Worlds of Fun Friday.
Oceans of fun.
Oceans of Fun too. It's gonna be so fun.
You think so?
It is.
Do you think they'll let me go?
Nope.
I don't know.
What's today?
Today's Thursday. My name is Angela Heron. I'm 34 and I live in Overland Park, Kansas. I'm gonna have a procedure done to get my tubes untied so that I can have another baby. I love Henry and I think we'll be happy with another kid. We are engaged to get married, but we haven't set a date yet, but he has gave me the ring. I really didn't make this decision. Henry made this decision. If it was up to me, don't tell him I said this, but I wouldn't have no more kids. When I was 18, I got pregnant by Henry, and I knew he didn't want to have kids, so I left. But I never told him about Vanessa. All these years, Vanessa thought that my son's dad is her dad. And I told her that Henry was her dad about 2 months ago.
Did your son's dad think that Vanessa was his daughter?
He still does. One of Henry's family members found me on Facebook and they told him I was on there. He looked me up and there I was.
Check in right here. And this is your spokesperson form. It's who you would like us to release your information to once you're out of surgery, like family members that are with you.
The success rate of this operation depends on the woman's age, depends on the type of tubal ligation she had, it depends on any other fertility factors. For Angela, her chance of getting pregnant is about 60 to 70%.
Well, a little nervous. I want everything to go right with Angela and her surgery, and then recuperate, and we're trying, and mistakes that we did in the past, correct them, have kids, have a family, have a house, and with the girl that I love. That's very important.
Once Angela's asleep, we bring in the robotic system connected to the instruments that I've inserted through the abdominal wall. Then I will go sit down at a console where I begin to manipulate those instruments. For women who've had a tubal ligation, they typically have the tube divided into two segments. And so what I have to do is identify the two segments. I have to open the ends of the tube and then sew them back together.
When my mom told me Henry was my dad, I felt sad and shocked. The father that raised me, that I see every weekend, our relationship is close. Like, he's still the one that I talk to about things.
Hey there.
How you doing, Doctor?
Hey, Angela's doing fine.
Good?
Yep.
Thank you.
Well, let me show you some pictures and talk about what we found. All right, this is where her tube had been tied on the right side. So here's a part of the tube there. There's a part of the tube down there. She's back in recovery right now, and she'll be there for a while. The nurses will come out and get you when she's a little bit more awake.
Thank you, Doctor.
You bet.
Appreciate
Congratulations.
it. Thank you.
It's good to see you, Vanessa.
Kansas City-based filmmaker Sharon Lee's tracking that story. She's out in Park City, Utah, where she's showing her latest film, Selfie, at the Sundance Film Festival. Sharon, tell us about Angela. How long has it been since her tube reversal surgery, and has she had any luck getting pregnant?
Angela had her procedure about 6 months ago, and she unfortunately has not gotten pregnant yet. I think she's going in for some more tests to figure out what's preventing her from getting pregnant. But the good news is that Angela and Henry did get married in September, and they moved to Leavenworth with Vanessa to start a new life. So I'm happy for them.
Sharon, thanks for the update. We'll be checking in with you later. Dr. Gelbach, I mean, what is the success rate after that kind of procedure?
For women who are under the age of 38, we expect usually between 60 and 70% to conceive.
Now, are you doing tubal, are you untying tubes over at the KU Medical Center, Dr. Krieg?
Absolutely, yes.
Okay, now, I've always been intrigued by this issue here of, can anyone get fertility treatment? Is anyone can come into your office and they get, if they've got the money, get treatment from you?
Well, not necessarily. A lot of it depends on the health of the mother and whether or not she can have a healthy pregnancy. So for some of our older moms that may have been diabetics for a while, that may mean getting cardiac clearance and making sure that it's safe for them to be pregnant. Patients with some genetic illnesses, we do quite a bit of counseling and perhaps pre-implantation genetic screening before pregnancy, so they go into the pregnancy with their best foot forward. So we do a lot of medical screening, so essentially doing prenatal labs before pursuing a pregnancy.
What about with you, Dr. Gelbach? Can anybody get fertility treatment?
Well, there are some barriers. For instance, age is one. You know, we know that as women get older, the chance of conceiving, even with assistance, goes down. And same thing,
So there's some patients you say no to?
Correct.
I've got $40,000, Dr. Gelbach. I really want to try this. And you're going to say no to people?
Well, Nick, if, let's say, someone who was menopausal, you know, I mean, she may just not have an awareness of what her chances of having a baby, having a healthy baby, or even with medical treatments, what are some of the risks of that pregnancy?
Dr. Lantos, while we were watching that video piece, you were talking about the public attitudes and the differences here between couples who are so desperate to have a child and the overall public attitudes and the disconnect there between those two groups.
So this last little interchange highlights that, I think. If you survey the general public, should insurance cover this, and they're given a choice comparing infertility treatments to other medical needs, they generally rate fertility treatments quite low. When Oregon did this and had a public discussion about prioritizing health services, fertility treatments were down at the bottom. But if you ask infertile couples how much they value it, they give astounding answers, like they'd be willing to pay $50,000 of their own money for a 10% chance of having a baby, even with a 20% mortality rate. So they are desperate to get this treatment. So if it moves from the marketplace, where people can get it if they can pay for it, to mandated insurance coverage, policymakers will have to make decisions about who to cover and for how many treatments at the national level or state level rather than at the individual doctor-patient level.
I mentioned in our open to this program that the state of Missouri was named number 48th among states on a national fertility report card. And now in the state of Kansas, it's not just becoming an academic exercise, this is really becoming a volatile political issue. This week, Kansas lawmakers debating a bill that would decriminalize surrogate motherhood, proposed by Shawnee Republican Senator Mary Pilcher Cook. The measure would make it illegal to pay women to be surrogates in Kansas, with violators facing a year in jail and a fine of up to $10,000 if convicted. Cook says she worries about women being exploited. Do you deal with surrogacy, Dr. Gelbach?
Yes, I do.
Yeah, so tell me about, I mean, is that a big part of your practice?
It's not a big part because there's not a tremendous need for it. The most common reason to use a surrogate or someone to carry the pregnancy is that the woman may have a medical condition that would be dangerous for her to become pregnant. And so if we restrict her access to having a baby through a carrier, then she would never have a child, or she would face going through a very dangerous pregnancy to risk having a baby.
How about at KU, Dr. Krieg? How much of do you see surrogate patients?
Yeah, we do gestational carrier cycles. And again, many times it's for, say, a woman who's had a hysterectomy because of, say, cervical cancer is something that stands out in my mind, or someone who's born without a uterus. Or I've had patients who've had organ transplants and are unable to safely go through a pregnancy, and it's really been almost a life-saving measure for them so that they can have a biological child.
Now, while this is happening in the state of Kansas, and there is an effort, of course, to ban the practice, at least on a commercial level, there are many progressive European countries, or we would view as progressive, from France, Germany, Norway, Sweden, who have banned surrogacy, and not just on a commercial basis, Dr. Lantos.
There's three different policy approaches you can take to surrogacy. One, the one proposed in Kansas, is to criminalize it. The second, which is much more common and I think is what most European countries have done, has been not to enforce contracts. So essentially that says the gestational mother is the legal mother unless she gives the baby up for adoption, and whatever arrangement is made before the pregnancy is not enforceable. They're not going to forcibly take the baby away from the woman who carried the pregnancy. The third approach is to legalize it. That's what California and a few other states have done, and they say these contracts are enforceable. You sign the paper when that baby's born, it belongs to the contracting parents, not the gestational mother.
Well, for all the attention on women who will go to great lengths and great personal financial costs to have a baby, what about those who will do anything not to have a baby? We'll take your calls in just a moment on 561 0006 as you join the conversation. But first, Cynthia has that story.
Next, we meet Stephanie from Tonganoxie. She's 25 and a mother of 4, and is definitely finished with having any more children. She wants desperately to make sure of that, so she's about to have a permanent sterilization procedure done today. It's called Essure, and unlike having your tubes tied, it's inexpensive and can be completed as an in-office procedure. But while it may not be surgical, it is irreversible.
You guys have any questions about mommy going to the doctor today? What?
I know. They're going to fix mom's tummy so she doesn't have any more babies.
That's right.
Yep, and you're okay with that, right? We got enough brothers and sisters? Yeah. My name is Stephanie, I'm 25, and I have 4 children. Our 2 older ones were planned, and our 2 younger ones were surprises. I made the decision to have the Essure done because I feel like we're complete. The reason I didn't get the procedure done a year ago when I wanted to is because my doctor didn't think it was a good idea. He thought I was too young. I'm 25, I've had 4 kids in the last 5 years. Like, why not get fixed? I think it was $3,500. The insurance covers $3,000 of it. And we talked about him getting the vasectomy, but I don't think that was the right choice. And his healing time, it would take longer for him to heal than having this done for me.
We weren't really looking at the cost of how much it was compared to any the other ones. We were mainly looking at what was the safer procedure and probably the better option, honestly. When you got 4 kids, it's hard enough to take care of 2, so when you have 4, it can get kind of expensive. So
the procedure is permanent, like it can't be reversed, and it's life-changing, really. Be a good girl, okay? Love you. Bye, love you. Be good. Bye. Bye, Daddy. Aww.
It's gonna be all right, babe. Everything's gonna go just fine. They're gonna numb you up. You're gonna be on a Valium. So you're gonna be feeling pretty good.
She said it should only take like 5 minutes. I hope so.
Yeah, like 5-10 minutes. So it's not gonna be anything bad.
I'm gonna be baby-proof.
And then you're gonna be baby-proof.
Stephanie. Hi. All right, are you ready for today? Yeah? Are you sure? Okay, the first thing we're gonna do is we're just gonna do your paracervical block, and that's just the numbing medicine we talked about that goes at the level of your cervix, okay? Now, I know we already met this week. I know we already went through everything, but do you have any other questions before we do this?
I feel good.
All right, now this is the block. I'm not going to show you anything, but you may feel a little stick, ouch, and burn, and just breathe. You're doing fabulous. You're halfway done already. Okay, so we are ready. Okay, right there, if you want to look, do you see the opening we're talking about? It's kind of like a little hole right there. That's where the tube comes into the uterus. And you're gonna see this literally slide right through that opening. Stephanie has chosen to have the Essure sterilization, which is all done vaginally. There's no incisions, we do it right in the office, no anesthesia, and it goes through the cervix into the womb, and you insert little coils into the tubes where they come into the uterus to basically plug the tubes up from the inside. Right in that opening, perfect. All right. And there.
Lots of cramping.
Okay, and we're gonna wheel it back. That's excellent. Just keep breathing. There's our markings. Release it. And perfect. Okay. You're officially done. It is recommended that Stephanie use backup birth control for 3 months. And then at the end of the 3 months, it is the only sterilization for females that require a testing done at the end. So she'll have to have an HSG, which is a hysterosalpingogram or a dye test, to make sure that the tubes are completely blocked and it's safe to come off all backup birth control.
You did it really fast. I feel okay. I feel like we made the right choice. Life is short, so we better enjoy it.
Joining us again is filmmaker Sharon Leese, who is currently in Park City, Utah at the Sundance Film Festival showing her latest film, Selfie. Sharon, update us on Stephanie. There's been quite a few headlines now about health complications surrounding this Essure procedure. Has Stephanie experienced any of the problems?
My understanding is that Stephanie went in for a 3-month follow-up with her doctor and everything was fine. So I know there's been some complications with the Essure procedure, but I don't think that Stephanie had any issues with it.
Alrighty, thank you very much, Sharon. Are you involved in the Essure procedure at KU?
We perform them at KU.
Okay.
I don't do them personally since it causes infertility. But
Okay, how about you over at Olathe?
Yeah, I'm devoted to infertility treatment and not to perform tubal ligations.
I should point out the FDA has received 943 complaints relating to this procedure, with pain being the top symptom. But the agency released a report in November that concluded that overall results from its study did not demonstrate any new safety problems. So that's the latest with regards to this particular procedure. We do have a caller on the line joining our conversation. And who do we have with us?
My name is Diane.
Diane, good to have you with us. Your question, please.
Why are couples not considering adoption more than having to have their very own baby?
Okay, so there are other options, aren't there, Dr. Lantos?
Certainly, and adoption is high up there on the list. I think the question of why is an interesting one. More interesting is whether people should have the right to make that decision for themselves. Now that fertility treatments are available, they do. People can choose to adopt, or they can choose to try to have their own biologic baby.
What happens when you go to either of your offices, though, and you've talked about people where you've said, I cannot help you anymore. Yes, you may have the money, but I cannot help you any longer. What options do you actually provide couples?
So we provide them information about adoption. We refer them to a counselor to discuss that is an adoption counselor, also to talk about things like embryo adoption, childless living, and really go through the gamut of their options. And we often do give information to couples about adoption while they're pursuing fertility treatment. And it's not uncommon, and you've probably found this in your own practice, to have a couple going through the adoption process and going through fertility treatment at the same time.
Does that happen?
It does, but I still encourage couples to go in one direction or the other. I think adoption is a wonderful option, but it may not be for everyone. And same thing, access to adoption is more limited today than it has ever been. International adoptions are greatly restricted, and there are just not enough babies to adopt here in the United States.
Well, we called this program Birthing Pains for a reason. For all those people who are so desperate to have a baby, there are so many more who will do whatever it takes, as I said, to avoid getting pregnant again. You just saw that particular video piece. Coming up next, though, you've seen all of those celebrities freezing their eggs so they can delay motherhood up until their 50s. Now the frontiers of medicine are making it available all across the country if you can afford what could be up to $50,000 price tag. Some women apparently wiping out their savings and borrowing from their parents to make it happen. I noticed even KU is now offering women the chance to freeze their eggs. Dr. Krieger, are you offering this?
We are. So we actually have had several live births from egg freezing, some of the first in the state. And we have really good success rates with our egg freezing. Now, in terms of reasons to do egg freezing, a large proportion of our patients that go through the egg freezing process are single women with a new cancer diagnosis, and they want to preserve their fertility prior to having surgery, chemotherapy, or radiation. And this really allows them to have children once they move to that survivorship mode and they've survived their cancer treatment. But we also do have some patients that haven't met the right man yet and want to be in a relationship once they have children, and they hear the biological clock ticking, and we freeze eggs at that point.
Are you doing that too?
We are. We're just beginning. I find it more useful in situations where couples who want to go through in vitro fertilization and have concerns about having too many embryos, that they want to transfer one or two, but not have many left over so that they couldn't use them for enough pregnancies. In that situation, we can freeze the eggs before they're fertilized, before they've become something that could create a pregnancy, and then allow them, if they don't get pregnant through the IVF procedure, to use the eggs, fertilize them, and therefore we're not creating an excess number of embryos.
So what is the survival rate after thawing the eggs?
So our survival rate with thawing rivals that of embryos. So we have about a 90% survival rate. And of those that survive the thaw, 80% fertilize normally, which is the same as we would anticipate for fresh. So we're at the point with technology where this is no longer experimental. This is a very viable way to create a pregnancy at a later date.
Now, how long, though, can women push then off being mothers? Exactly. I mean, are we going to be seeing geriatric mothers having babies into their 50s and 60s?
That's an excellent question. And actually, our governing society has put a cap on that, but we don't recommend pregnancy past the natural age of menopause, so not past the age of 50 or 51.
So you can do this up until the age of 51?
Yes.
Wow.
But that's what our policy is at our center. But these women, once you get over the age of 45, we do require quite a bit of medical clearance, making sure that their heart's strong enough to sustain a pregnancy, making sure that they don't have any other illnesses that would compromise a pregnancy.
And what problems and challenges does that create, do you think, Dr. Lantos?
If you look at all the ethical issues around fertility, reproduction, contraception, abortion, IVF, they all expand women's reproductive freedom. They all give women, they all level the playing field for women compared to men. So men have always been able to have children into their 50s, 60s, 70s, or 80s. All this does is equalize reproductive freedom a little bit, not completely, of course.
Okay, I want to get back to this in just a moment, but we do have Kim in Grandview on the line with us. She wants to join our conversation. Kim, good to have you with us.
Hi.
Hello.
Hi. I was wondering, I'm 38, and my husband and I have been trying for 3 years, and we've gone through 3 rounds of IUI. What are my chances of getting pregnant on the first try with IVF at my age?
Okay. Dr. Gelbach?
Again, there may be some qualifiers there, but in general, women who are going to be in their late 30s, it would be somewhere in the neighborhood of 40 to 50%.
Okay. Is that the news you wanted to hear, Kim? Is she gone? Okay, she's gone. Okay. We were going back to the freezing of eggs here. Should there be an upper age limit, Dr. Lantos?
Well, the upper age limit should be determined by what's physiologically possible. And I'm not the expert on this, these doctors are, but the older a woman gets, the harder it is to achieve a pregnancy and certainly to have a healthy baby born at the end of it. So the real tension is between this expansion of women's reproductive freedom, which I think is a good thing, balanced against the risks to the children who will be born from these pregnancies. And the higher the risk to the prospective children, I think the more ethically problematic it becomes. With IVF, there's a higher rate of multiple pregnancies, especially if you transfer two embryos. Twins are more likely to be born prematurely. Premature babies have lots of problems, and that's an issue with IVF, even in a healthy 35-year-old woman. Once you get up to 50 or 55, those risks go up.
Which is a question of how many eggs should be implanted.
Right.
Should there be a limit on the number of eggs implanted?
From the perspective of the health of the baby, single embryo transfer is the best. Singleton pregnancies are much lower risk than multiple pregnancies. So one of the advantages of public funding is, in places that have public funding, they can mandate single embryo transfer because public funding allows public control. When, as in Kansas and Missouri, there's no public funding and people can make their own choices about what should be done with their own dollars, they can choose how many embryos to transfer, governed only by the professionalism of their fertility doctors.
On our Twitter feed before we started the program, somebody was asking about whether fertility treatments actually also increase. We talked about having premature births, multiple births, but whether this was increasing the number of birth defects. I mean, is there any validity to that, Dr. Krieg?
There is. We know that infertility itself does slightly increase your risk of birth defects. So even if you have a couple who conceives on their own after 5 years of infertility, they do have a slight increased risk of birth defects. And it's the same as those who undergo in vitro fertilization. Now, patients who undergo in vitro fertilization where they've actually had to biopsy the testicle of the male to retrieve sperm, those pregnancies, if they have a male offspring, are at somewhat higher risk of having male urogenital birth defects. One of the more common ones we see is hypospadias, where the opening that you urinate out of is a little bit larger, so the boys have problems with dribbling and whatnot. It's a simple surgery to correct. But that's something we counsel our patients about that have severe male factor infertility, is that that child may also have infertility themselves. They may have some basically reproductive difficulties themselves. But in terms of birth defects, it's only a slight increase from about 2 to 3% in the general population to about 4% in the infertility population.
Dr. Gelbach?
Yeah, some of the studies say that it's not necessarily the technology, but the couple that requires that technology that places them at risk. And so when there are very minor problems with reproduction, there's a slightly increased risk. But as it takes more and more treatments, or the ones that have the more severe types of infertility, they're at risk of a child with a birth defect because of that, and not necessarily from the technology.
Do multiple births have complications?
Absolutely. Even if they're not premature, they're at higher risk of the mom being affected by things like preeclampsia, gestational diabetes, that can affect the pregnancy themselves. And some of these effects with, say, diabetes, we're just starting to learn what the long-term health impacts on diabetes and pregnancy is for the offspring, irrespective of mode of conception. But certainly multiple births are at higher risk.
So all of this, though, as a general public, you talk about public attitudes, Dr. Lantos, about the difference between couples and the general public, those who are desperate to have a child. But there was a study done, and I have it right here, about the difference in price between somebody who's been on fertility drugs has twins. The cost from birth to discharge in a hospital is $135 $100,000. I mean, there's a huge cost associated with all of these treatments, and people going to these intensive care units. There's a huge societal cost to this, isn't there?
I haven't seen that study, or not sure which one it is, but I assume most of that cost is because of multiple births. So twins who are born prematurely, and the cost is the cost of the neonatal intensive care for the premature babies, rather than an increased cost for the fertility treatment itself. So here's the tension on public funding. If you have public funding, you can regulate how many embryos are transferred and have more single embryo transfer. Individuals who seek that out aren't punished financially, because even if they have to do 2 or 3 cycles to get a pregnancy, it doesn't cost them anymore. It increases the risk because each cycle has its own risks, but it doesn't increase the cost. And it lowers the cost to the public insurance system in down the road costs for the neonatal intensive care. We in Kansas and Missouri don't pay for the IVF. More people choose to have 2 embryos transferred. They're more likely to have premature babies, and our insurance does pay for the neonatal intensive care. We may be paying more by not covering IVF.
Do you have a response to that, Dr. Gelbach?
There's very good evidence that adding infertility benefits to health insurance only increases healthcare costs by a couple dollars a month. It's a small cost, and I agree, it's a lot of this economic tension between, well, if I put in 2 embryos, you know, it's a little better pregnancy rate. Is it worth me having to maybe repeat another cycle of IVF to get a pregnancy? And I wish we had that type of healthcare coverage that made it fair. You know, what we try to do is to advance our field so that we can identify that embryo that's going to be a pregnancy.
Okay, Harold in Independence is on the line with us. Harold, your question, please.
Yes, I wanted to take this opportunity of the great show you guys have here to actually thank Dr. Gelbach for my 17-month-old daughter, Clara, I have here. Me and my wife had a tubal reversal done in right around April of 2011, and we got conceived in December of 2011, and she was born in September of 2012, and it's the best thing that ever happened to me, and this is such a great opportunity to tell him thank you on the phone here. My name is Harold Holler, and my wife's name was Patty. He may remember us, but it was one of the greatest things that ever happened to us.
So obviously then price was no object then. This was very much worth it to have this new life in your family.
The price was no object for us. I would have worked 3 jobs if it would have taken.
Yes. Well, Harold, thank you very much for joining us. Joanne in Prairie Village is on the line. Joanne, you're probably going to celebrate Dr. Krieg. Oh, okay, perhaps not. Okay. What is your question?
This is Joanne.
Hello.
I had a question about I've been reading recently about the age of fathers having an influence on the problems that might develop with the pregnancy. Can you comment on that?
Great question. Dr. Krieg?
So we do know that as fathers become older, there is a slightly higher risk of autism and autism spectrum disorders. And there was a very nicely controlled study that came out a few years ago that's showing after the age of 41, there you do see a slightly higher risk. It's actually about a 5-fold increased risk of autism and Asperger's syndrome.
How about the age of fathers being part of the problem here, Dr. Gelbach?
It is definitely less an issue than the age of the mothers, I will say that. I think there is a slightly increased risk of chromosomal issues in the offspring in men over the age of 50. But again, these are very small contributions or small risks compared to the majority of men over the age of 50 are able to have very healthy children without difficulty.
When we hear about this fertility problem, I mean, is this the inevitable fallout of Americans wanting simply to delay motherhood until later in life? Is it as simple as that?
I think that's part of it. I think part of it too is just access to more reliable contraception so we can plan our families and the size of our families when we're ready. Also, a lot of people are divorcing and having second marriages, and that ends up delaying child rearing as well.
Is it simply that, or is there any environmental factors, or is there anything more to it, Dr. Gelbach?
I think environment plays a small role. There are still many reasons for infertility that are not societal. But it is true that we tend to put off having children until we've completed our education, we're secure in our career, we're financially stable. And what people don't always recognize is that by doing that,